Hi, I'm Dr. Jared Gardner. I'm here today with my awesome pathology and dermatology residents, and we're going to do some deposition and metabolism type derm path cases. So, who wants to take case one?
I can take this one.
Okay.
So it looks like we're looking at something that's deeper down in the dermis, and it kind of is like purple. I think you can describe it as like arabesque in shape. So this is good for gel foam.
Very good. Yeah, this is gel foam, so it's, used, as you guys know, after certain surgeries. You can use it, I think some people like to do it after a punch biopsy instead of a stitch. And it's used in various other internal surgeries. So every once in a while you see it left in tissue. And it has, I guess I'd never heard of or thought of it as arabesque, but I guess it kind of is. I kind of think of it as almost triangular shaped, but then twisting at the edges. That's weird. I'm hearing like an echo. Sorry. All right, I always think of it as kind of like purple triangles that have like edges that spin away. I don't know. That's what it looks like to my mind. But whatever way you describe it, once you've seen this, you're like, oh, that's a thing. I know what that is. So that's gel foam, and it's a foreign material. And of course, anytime you see gel foam, pretty much always you're going to also have biopsy site reactive changes, right? And look what we got up here. We've got normal skin on this side on the right, normal-ish skin on the left, except for probably a bit of maybe a little residual melanoma in situ or something. I don't know the history on this case, but it looks like a residual melanocytic lesion there. But in any case, here is the reactive epidermal change and dermal scar and granulation tissue that represents the site of the previous biopsy. So this is probably like an excision of a melanoma, I would imagine. And then this was the biopsy site, and then there's gel foam down here. And then underneath the gel foam, we've got some foamy histiocytes and a little inflammation, and that represents fat necrosis. And just as a contrast here, once we get this into clearer focus, this is fat necrosis, and this is gel foam right there. So a little bit different, right? But you could also, sometimes necrotic fat can look a little bit wiggly and squiggly and arabesque-like in lipodermatosclerosis. And so sometimes necrotic fat cell membranes can mimic foreign material occasionally. So, all right, good. Gel foam. Case 2.
I can do this one.
Okay.
So kind of like nodular structures in the dermis
Good.
with this chunked up purple material. So it looks like calcium deposits and then some fibrosis around them. So I think looking at the site too is helpful.
Yes. Are there any clues to the site here?
I think there are. So there's kind of bundles of smooth muscle. So probably on like a genital site or maybe like nipple if you see smooth muscle. So this would be good for idiopathic scrotal calcinosis.
Yeah, very good. These are abundant smooth muscle bundles, way more abundant than you would expect for normal erector pili muscles that are, one per hair follicle. But there's tons of them all right here jumbled together, and a lot of them are kind of small. See how little some of these are? When you have a lot of smooth muscle bundles deep in the dermis and many of them are smaller, right away I'm going to suspect that we're in a genital site, and that would be usually the scrotum or the embryologic homologue of that, the labia majora, right? And also you can see sometimes in the skin of the penile shaft and other places in the genitals, but generally genital site when you see a lot of little smooth muscle bundles down in the deep dermis. Nipple, like you said, and areola also have a lot of smooth muscle bundles, but they tend to be a lot larger. And there is a little kind of subtle difference there. But in any case, nipple, areola, and genitals is a good places to think of when you see smooth muscle bundles. And as you nicely described, there's multiple nodular aggregates of chunky and granular kind of calcifications in the dermis. So when you have that on the scrotum, that's called, like you said, idiopathic scrotal calcinosis. And people have debated over the years why this happens on the scrotum, if this is a type of just calcinosis cutis, which to me this looks identical to calcinosis cutis. Some people have postulated that maybe these arise as types of epidermoid cyst that then subsequently calcify. I can't remember what the current thinking is. I've always had a little bit of a hard time buying that because I never see squamous epithelium with these. I always just see nodular aggregates of calcium with adjacent fibrosis. So it doesn't, I don't know that it matters, but anyway, these tend to be multifocal, multinodular on the scrotum, and kind of a yellowish to whitish look clinically in many cases. You may have epidermal reactive hyperplasia over top of it. And then the calcium, just like in calcinosis cutis, it can range from being big, large chunks or fine, powdery granules, and it's going to be purple and refractile here. You can see how the fragments are all different shapes and are really falling apart because they are hard to cut through on the microtome in the histology lab. So if you had this anywhere else, you would just call this calcinosis cutis. If you had a similar looking appearance like this down in a deep soft tissue site or in a joint, you would call it tumoral calcinosis. All of them are basically aggregates of dystrophic calcification, and they all look very similar microscopically and just have different names depending on the different context. Good job. So scrotal calcinosis here. Case 3.
I can do this one.
Okay.
So looking at it from this far away, the epi looks pretty normal. It looks like most of the dermis. And what you can see is there's kind of a homogenized pinkness to the dermis. And then when we go in a little further, this looks pretty good for amyloid. You can see some cracking in it as well as some pigment incontinence. And so for this, I would say macular amyloid.
Yeah, very good. This is sometimes incredibly subtle, and unfortunately, I mean, this is not, as a scan goes on this system, it's not too bad. But I mean, even with the best of situations, this can be something that's pretty subtle. You have to often, if you're really good, you might notice it at low power. But usually you have to go high power. From low power, I would say this is one of the invisible dermatosis, situations where the skin looks normal or almost normal in many cases. From lower power, it's usually on like the back. You'll have like pigmented patches or thin plaques on the upper back. There's debate about what causes macular amyloidosis. I think a lot of the times my understanding is that people have attributed it to some degree of rubbing or chronic irritation change. And so what you get is deposits of pink amorphous material in the papillary dermis. And let's see, there's a little bit more over here. And sometimes it's hard to tell this apart from just normal papillary dermis or from basement membrane. That could be a little thickened in some situations. So here's what's going on here. Oh, and by the way, the deeper reticular dermis here does have a little bit of blue stuff, probably just solar elastosis. I guess you could also think of mucin, and it's hard to tell the difference here on this scan, but I think it's probably just some solar elastosis. But in many cases, the rest of the dermis looks totally normal, no inflammation. But the material here is pink, it's homogeneous, it's pale, and it has little crack artifacts between it, like amyloid typically does. This is not associated with light chain amyloid or systemic amyloidosis, okay? Really important to remember that. And in fact, when I make a diagnosis of macular amyloidosis or the closely related entity like an amyloidosis, which I'll mention in just a minute, those are both keratin-derived amyloids. So what happens is the keratin and other proteins from degenerated and dying keratinocytes drop out from the basal layer, deposit in the papillary dermis, and what comes along with them is the melanin pigment that is normally stored in the basal layer keratinocytes. See right here, these pigmented brown cells, as most of you probably know, but any beginners watching online, the brown cells in the basal layer are not melanocytes usually. They are actually keratinocytes. The melanocytes make the melanin. This gray guy right here in the middle, that's a melanocyte. No melanin that you can see. They make the melanin, but then they feed it to their neighboring keratinocytes. The keratinocytes store it. But when the keratinocytes get injured or die, and you can see one dying right there, that orangey looking keratinocyte with a shriveled nucleus, that's a apoptotic keratinocyte, necrotic keratinocyte, dyskeratotic keratinocyte. Sometimes once the nucleus goes away, people call them cytoid bodies, Savant bodies. All these different names are all mean dead keratinocyte in the epidermis, okay? We just have to have 55 names for everything in derm path, okay? So what happens, they die, and then their keratin falls into the dermis, and it gets all clumped together here, and those cracks between it are present. Here's nice cracking artifact. I find that really helpful, the cracking artifact, and like you very nicely said, the pigment gets trapped in the middle because the pigment and the amyloid are both coming from dying keratinocytes. The pigment, melanin pigment, gets trapped in between these dying keratinocyte fragments, and it gets all smushed together in the papillary dermis, and that is the evidence that it's keratin amyloid, the fact that it's in the papillary dermis and the fact that it has melanin pigment trapped in between it, okay? On staining, it will often stain similar to light chain amyloid, but the location is different, okay? So they'll stain like very nicely, supposedly with Congo red. I find Congo red very a difficult stain to get to work correctly, to be quite honest. I much prefer thioflavin T, but you have to have a fluorescent microscope to examine it, but it glows beautiful bright green on thioflavin T, just like regular light chain amyloid does. The difference is that it's here in the papillary dermis and has the melanin, whereas systemic amyloidosis, the kind that's associated with light chains and with plasma cell neoplasms, is going to usually be down in the deeper dermis around blood vessel walls, okay? Or sometimes making a big diffuse nodule filling the dermis, but not just limited. I've never seen a case of systemic amyloid that was associated only with the papillary dermis. In my experience, I've never seen that. So whenever I make a diagnosis of macular amyloidosis, I say this is keratin-derived amyloid. It is not associated with systemic amyloidosis or light chain amyloid. Because I have seen people before that got referred into an amyloid center and were sent for a bone marrow biopsy because of a diagnosis of macular amyloid that the treating doctor, probably a non-dermatologist, did not understand was totally unassociated with systemic amyloid. So after seeing that one time, I ever since started adding to my reports just in case any non-dermatologist or patient reads it and freaks out thinking amyloid, because amyloidosis, systemic amyloid, is a terrible disease that's very problematic. So I like to make sure people know this is a benign condition that may be annoying but is not associated with a life-threatening disease like systemic amyloid. Now, lichen amyloidosis is a similar, exact same kind of process of dying keratinocytes and amyloid and pigment trapped in the papillary dermis, but it usually is on the anterior lower legs, on the shins, and it's usually more abundant amyloid and associated also with reactive epidermal hyperplasia, papillomatosis, hypergranulosis. It basically has like lichen simplex chronicus changes in the epidermis plus amyloid in the papillary dermis, and usually it's very itchy. People scratch and pick at it, and I've had people comment on it. I've got another video that mentions it online, or I posted it online once. I can't remember, but some people have responded and said it's a very unpleasant condition to have. So again, unpleasant, morbid, definitely problematic for the patient, but not associated with systemic amyloid. All right, so that's a good one to know. I know we talked about that at length, but it's important because it can get mixed up, and it's also hard to identify at first glance. And the one last thing is a lot of people in books like to talk about, because it's keratin-derived, you can stain it with keratin immunostains, particularly like CK56, like a high molecular weight keratin. I have tried that over the years. I have found it to be disappointing. It does give you some staining, but I find that not all of the amyloid stains. You might get some little fragments of staining in there, but I often have tried it, and I have not found it personally to be that helpful, and it doesn't look as good as I would expect that it would. So in any case, I think part of the reason is that the amyloid is not purely composed of keratin. I always was under the impression that it was, but upon further investigation, there are other proteins that get mixed in there with the keratin, is my understanding. So there you go. Now, case 4.
All right. I can.
Okay.
All right. First glance, really big, like compact corneum, so more than likely we're on an ankle site.
Good.
And especially in this left piece here, we can just see this like cleared out area. It kind of looks to be cystic, but
yeah, it's cystic right here, and then here not really. Here it's kind of very loose and pale and has some scattered spindle cells floating around in it. So what's going on here?
So it appears, this cleared area looks like a lot of mucin. puncture the little spindle areas. I mean, hard to tell from here, but I'm betting they're fibroblasts.
Yep.
Probably helping produce this mucin, and so this is the digital myxoid cyst.
Yeah, so this is digital mucus cyst, digital myxoid cyst, whichever you like to call them. And they are little kind of clearish papules that arise on the proximal nail fold. So the dorsal surface, where the skin meets the nail. For anyone watching online who's not familiar, you can go Google that terminology to see. But that's the site where these arise. And you have two different patterns that you can see in digital mucus cyst. One is an open cystic space filled with bluish or pale mucin or myxoid material, okay? It's very pale here because I find that mucin tends to start to fade very quickly on H&E slides. It's one of the first things to start disappearing as the slide gets older. And this slide's a bit older. You can tell the epidermis is kind of pale. So that's why it looks almost clear here. But in a fresh example, it's often kind of bluish. But do note that sometimes, depending on tissue processing, sometimes once you cut into it, all the mucin falls out and it washes away during processing, and you do get a just empty clear space. So it can either be an empty white / clear space, or it can be filled with bluish stuff and kind of debris. And it's a cyst, and it's not lined by any epithelium. So it's like a pseudocyst, actually. It's a cystic space, but not a true epithelial cyst, right? It doesn't have any epithelial lining. It may look almost like a little subtle synovial type lining sometimes, but usually it looks like this, like no lining cells. So that's pattern one, a pseudocyst filled with mucin or myxoid material or washed out and empty. Number two, though, what happens is sometimes the myxoid mucinous material leaks out of the cyst and infiltrates the adjacent dermis. And what you get then is this loose myxoid pale dermis with floating spindle to stellate fibroblasts or myofibroblasts floating around in that mucinous material, okay? So either of these patterns or both are perfectly fine, in my opinion, for digital mucus cyst, okay? And the analogy, this is analogous to me to ganglion cyst. So if you had a similar appearance, either the right side or the left side, if it looks like this and it's down deeper and it's a little nodule that connects down to a joint space, at any other anatomic site, you would call this a ganglion cyst. Ganglion cysts often have a thicker wall. They sometimes have a true synovial lining, sometimes they don't. I find that some hand surgeons use digital mucus cyst and ganglion cyst interchangeably. In DermPath, in the past, people have sometimes liked to say, well, a true digital mucus cyst should not connect to the underlying distal interphalangeal joint, but a ganglion cyst does. I don't know who makes these rules, but one of the forefathers, I think, has decreed that. I don't care, honestly, because both of them have the same kind of meaning. They're a benign thing, they're cystic, and in any case, just so you know, that's the distinction that some people make. But to me, microscopically, digital mucus cyst and ganglion cyst have essentially the same appearance. Just ganglion cysts usually are deeper down, and digital mucus cysts usually are right here in the dermis, underneath the epidermis, and you'll have various amounts of reactive change from people rubbing at it, some dilated blood vessels here. So anytime you see either of these patterns in the proximal nail fold, digital mucus cyst. Okay, case 5.
Alright, so for this one, the low power, we see the main feature on this one is the brownish yellowish discoloration in the superficial dermis that's replacing these collagen fibers.
Yes.
And this is when we go maybe in the high power has these like curvy shape, like or banana shape structures. So this is good for ochronosis.
Yeah, what a beautiful example too. This is very pretty microscopically. Like once you've seen this, you know what it is, right? Ochronosis, you've got these brown banana-shaped bundles of fiber that have a brown pigment deposited on them. And I find that to my eye, they look like they could either be collagen fibers or thickened elastic fibers. Like, see these little squiggly ones? Those are clearly, to me, elastic fibers. The bigger ones, I'm not sure if they're thick elastic fibers. I think some of them seem too thick and are probably collagen. So I feel like both types of fibers can get this brownish orange pigment deposited on them. And there are two different times where you can see ochronosis, right? There is the endogenous form that is seen in what condition? Anyone?
So we see them either in, if it's inherited in alkaptonuria,
Good.
or if it's acquired, we can find it on medication like hydroquinine.
Yes, very good. Very good. Yes, if you have the inherited form that it comes from the syndrome, then that's alkaptonuria, and that's when people, I believe it's homogentic acid oxidase deficiency, and they get pigment buildup, and they also get black urine and some other things, right? So we learned about that in med school. I don't know that I've ever actually seen a real case of alkaptonuria, like inherited form. I feel like we don't encounter ochronosis very often, but when I have seen it in practice, I think it's always been exogenous in my experience so far that I've seen. So I don't know what the actual incidence of each type is, but I feel like the few cases I've seen have been from the use of hydroquinone. And there may be other drugs that can cause it too, but hydroquinone is the one that I always think of. So very good. And so it causes like a pigmentation that can be seen clinically too, and then microscopically it looks like this. Very distinct. Once you've seen it, you'll recognize it forever. So a perfect example of ochronosis. Number 6.
We see this like pink kind of amorphous lobulated areas in the dermis.
Good.
Yeah, when we go high power on these, they like surrounded by kind of histiocytes, I think.
Yeah.
You can say like kind of palisaded histiocytes around those. And those usually, like in the high power, it looks like a little bit needle shape and feathery appearance.
Very good.
So I think that's good for gout.
Yeah, very nice. This is gout or a gouty tophus, tophaceous gout, whatever way you like to say it. And gout, as you perfectly said, you get these pink aggregates that are nodular. Now that it's finally in focus here. And you will often see that these are kind of like the shadow of the crystals, which have dissolved during processing and staining. It's always been taught to me, at least, that it's formalin fixation itself that dissolves the gout crystals. And but I've also read some literature that suggests that actually it probably has more to do with the H&E staining process itself, and maybe also something during the processing of tissue. But in any case, when we get normal tissue that comes in through routine formalin fixation and processing and H&E staining, the gout crystals are almost always dissolved. Sometimes you'll get lucky and you'll see an area in the pink that looks like brown and more refractile. If you see that, go and put your polarizer in and you'll see the beautiful polarizing needle-shaped crystals. But even without polarizable crystals, this pattern is so distinct. This has got to be gout. Like nothing else looks like this to me. You get the pink nodules that look kind of like fluffy clouds or cotton candy, but then you can kind of see these little thin needle-shaped clefts in this fluffy material. And then around the outside, you can see histiocytes and giant cells, often kind of a robust, thick layer of them, making a granuloma that surrounds these aggregates. So that helps you know this is material that's depositing here that the body does not like, and it's trying to wall off with granulomas. So that's an area, and then here's some lower power. And you can see it at kind of any level of the dermis. You can see it in the deeper soft tissue. You can see it around joints. I have seen it actually destroy the complete, in the digits. I've seen it destroy the phalanx bones. Like I've seen it deposit so extensively in the middle of bone that on radiology it looked like osteomyelitis and resulted in a toe amputation. And I think that the amputation probably was appropriate because the bone was completely destroyed by the gout, just like osteomyelitis would have destroyed a bone. It just completely disintegrated the bone. I've never had gout, but from comments from many people online, it is exquisitely painful and miserable. So I feel for the patients who suffer from this condition. So a very nice example of gout. And if you are watching this and you're a dermatologist or a treating physician, it is nice if you suspect gout when you do the biopsy, please cut it open, or if it's already broken up, and smear some on a slide. You can submit the tissue in ethanol instead of formalin, and notify the lab that suspected gout so that they can process it differently. That can be helpful, but I find also you can just smear it directly on a slide and air dry it and send that to the lab, or just put it under a microscope and polarize it yourself. You don't need to cover slip it or anything. You can cover slip, but even without a cover slip, you just put it under there and polarize it, and you'll see the crystals beautifully. So even without processing the tissue, that's actually really the best way to see gout, is just to smear it on a slide dry and polarize it. And if you want, you can put some mounting media and a cover slip, and you can still look at it that way. So I find that really savvy treating physicians will often do that, or they'll tell the lab so that our lab can do that at the time of receiving it, or they'll submit it fresh or on saline and say, please smear for gout, and then they'll smear it and then go on to process it. So we'll get both this type of specimen as well as the crystals. So I've been very pleased with my lab here and my submitting physicians in my current practice who are all very savvy about that, and I always get these beautiful gout smears along with a specimen like this, and that's just a great way to confirm the diagnosis. So that's gout right there. Good example.
All right, so low power, we see some hyperkeratosis, see some acanthosis, and what looks to be like a reticular formation of a seborrheic keratosis.
Very good.
And then if we were to go in at low power, we can kind of look in this lighter pink area.
It'll get there in a minute, I think,
yep.
Hopefully. But yes, from low power, like you said, it looks like a perfect seborrheic keratosis. Acanthosis, interconnected strands of keratinocytes with some increased pigment and nice, beautiful horn pseudocysts that you can see in some areas opening to the surface. And anyone who's a beginner watching this is one of the many different patterns of seborrheic keratosis. There are many different types of appearance that they can have microscopically. You can see there's some inflammation like we often see in seborrheic keratoses. And then here, finally, those pale pink areas are coming into view. So now tell me about those, please. What's going on here?
Okay, so if we look at the pale pink areas, we see some scattered deposition of pigment, and then we also see kind of this pink amorphous little balls that could be the keratin-derived amyloid with the cracking that we see.
Beautiful, exactly. This is pink keratin-derived amyloid filling the papillary dermis, just like in the case of macular amyloid that we saw earlier. It's the same exact process. It's just that here it's occurring in association with this seborrheic keratosis, but it's the same thing. Pink amorphous deposits with cracks in between them and trapped melanin pigment. And here you can see a little more clearly how the process happens. It is actually dying keratinocytes falling down from the epidermis and getting smashed together in the papillary dermis. Basically, they're like savate bodies, cytoid bodies, dead keratinocytes, and they're getting crunched together. So you can see how that process looks. That basically, if you get a lot of cytoid bodies or savate bodies or dead keratinocytes packed together, it makes the keratin amyloid, okay? And you can look over here and you can see it in action right there. You can see this kind of dying keratinocytes and almost interface type change, and then the dead keratinocytes falling down and getting squished together in the papillary dermis. So a great example of that keratin-derived amyloid process in action. And here it's just it's a lot more abundant than we saw in the macular amyloid. And it's just incidentally seen in this seborrheic keratosis. And you can see it, you often do see this in association with seborrheic keratoses. You can also see it with a variety of other epithelial neoplasms, including basal cell carcinoma, sometimes benign hair follicle tumors, and others. So anytime I see this, it's a pretty thing. I point it out to the resident who's sitting with me, and then I sign this case out as inflamed seborrheic keratosis. I do not mention the amyloid in the comment or anything because it doesn't matter clinically. There's no way that this could be, in my opinion, no way this could be systemic amyloid or light chain amyloid because you can see the cytoid bodies there, you can see the pigment. It's only in the papillary dermis. I've never, to my knowledge, seen a case of systemic amyloid present in this manner. So I just don't mention it. I guess if the only reason you'd mention it is that, like in the microscopic description, if you wanted to make it so that you could easily search for it later for teaching purposes. But in that case, just write down the number or get yourself a teaching recut now. I don't put it in the report because I don't want someone to read it and freak out when it's totally benign and incidental finding that's pretty but doesn't mean anything clinically. So this is just a fun microscopic curiosity that's important for pathologists and dermatopathologists to know about, so that they don't see this and freak out and think it's something like systemic amyloid. So that's the main reason we're having this conversation now, is so that when you see this, you know, oh, cool, that's pretty, and it doesn't mean anything bad for the patient. So, you know, I like to say there are 3 reasons why we split and make these little distinctions about things. The first one is because it's something important for patient care, right? We treat it differently, or it has a different prognosis. That's the most important reason that we split entities into different subtypes. And so we do that, and we mention it in the report, and it's important because it's going to change patient care. The second reason is because we do it so that pathologists or anyone looking at the slides knows, hey, this looks different than other examples, but it doesn't mean anything probably clinically. So, you know, this is just a variation of a benign seborrheic keratosis, or this is a different pattern of dermatofibroma that looks very different from other dermatofibromas, but still benign and doesn't need any different care or any different treatment. And the third reason that we split entities out in medicine is because people have to get published, right? And so you can laugh, it's kind of funny, but it's also true. So that's my, I don't know if anyone's ever described that before, but that's my Gardner's theorem of splitting. If someone wants to name it that, then we can. Then I'll finally have an eponym, because I'll never get an eponym or anything named after me otherwise, because Gardner syndrome's already been taken long ago by someone who's not related to me. So, and there you go.
I can take this one. So,
okay.
Since there is no epidermis here really deep to the facial and subcutaneous fat.
Good. Yeah.
And even this low power, I can see some like black dots.
Yes.
In the septate of the fat.
Yes, there are little dark dots of varying size in the fat all over in here. Lots of little dots.
Yeah, and then this dots, I think, in the really small, tiny vessel. So this one is good for calciphylaxis.
Yes, very good. And once it comes into focus here, we will talk about it in a little more depth. But correct, this is calciphylaxis. This is a kind of complicated topic, and I'm not going to go as in-depth into it as I could, but I do have another video about this online if you want to watch it that goes in more depth and has really good examples and good pictures of like very classic findings. But this case is pretty good here. The very short summary is that calciphylaxis is a very bad complication that occurs in some patients with end-stage renal disease, chronic kidney disease, end-stage renal failure, basically. People that have elevated BUN and creatinine. The vast majority of cases occur in that setting. There are rare cases that can also arise in patients who are not uremic. Okay? Clinically, these present as usually very painful ulcers that get black and look like black dead infarcted ulcers, or eschars is a term that's used for that. And this is due to tissue ischemia. And what happens is that as the patient's end-stage renal disease progresses, they begin to get dystrophic calcifications that deposit all throughout their body, but particularly in their soft tissue, in the subcutis, and around the walls of vessels. Big vessels can have calcifications from other things, incidentally, like Monkeyberg's calcific stenosis, and atherosclerosis, but in little tiny vessels is the most important finding here. So the clinical scenario, a renal failure patient with black eschars that are very painful usually. They are often taught as being on the abdomen, buttocks, and thighs, the kind of fattier sites of the body, but I also sometimes see them on the lower leg, the distal extremities, the ankle. I've seen them at other sites too. But they tend to be very painful, and it's an important thing to keep in mind anytime someone has a non-healing ulcer and they have renal disease, chronic renal disease. So if you're watching this and you're a medical student or a treating physician, please always keep that in mind, because I find nephrologists are very familiar with this, dermatologists are very familiar with this, many other doctors are not as familiar with this disease. It unfortunately is a very serious disease, it's very painful, and many patients die from it. So it is a diagnosis not to be made lightly, but also you don't want to miss it. Unfortunately, there's debates about how to treat it, and different things have been tried, but it's a difficult disease to treat and is difficult. So the problem is that you can find little calcifications in the subcutis or the dermis, incidentally in people, particularly in older people, on the legs. And so what exactly is enough to call calciphylaxis is somewhat subjective and a matter of debate. I personally feel that I have a kind of a lower threshold for calling it versus some other colleagues in pathology I feel that who expect to see more. But usually what I like to see is if I have the skin surface, I want to see ischemic necrosis or some evidence of, acute epidermal infarction and or proliferation of vessels in the dermis that are a sign of chronic progressive ischemia. And again, my other video goes into that and shows some examples. And then to me, the gold standard finding is that we have the clinical scenario like I just described to you, and that microscopically we see small fragments of calcification in the walls of tiny little vessels in the subcutis. To me, that's the best finding. You will also often see little granular calcifications in between the subcutaneous adipocytes. You may see them also in the fibrous septa. You can also see little wiry elastic fibers that are calcified that look kind of like Pseudoxanthoma elasticum, PXE, but you can see those kind of calcified elastic fibers incidentally in people who do not have calciphylaxis too. So that by itself to me is not enough to call calciphylaxis. I really want to see it in the vessels. A lot of times the little vessels will get like a donut ring of calcification around them. I find that pretty specific. Little tiny vessels do not tend to get a lot of calcium deposits in other conditions in my experience. I don't see calcium deposits around tiny vessels in, say, atherosclerosis, or Monkeyberg's calcific stenosis is usually in larger kind of muscular arterioles or small arteries and medium arteries, not in a little tiny vessel. So I'm looking here when this comes into focus to try to find better vessels here. Also, there's usually going to be fat necrosis, there may be hemorrhage, there may be fibrin thrombi in vessel lumens. So that's what happens is as the calcium deposits get put down, the vessels start to thrombose, they get blocked off, and you get ischemia that leads to infarction of the skin and these very painful black eschar-like skin infarcts that ulcerate. And again, a very serious disease that is potentially life-threatening. And in my other video online on YouTube, to my surprise, the video is aimed at pathologists mainly, but I've had multiple patient family members come and comment there that they lost a loved one to calciphylaxis and that it was a miserable, terrible disease. So I really feel for those people, and I feel that this is an under-recognized disease in pathology, and I want to make sure that everyone's aware of it because it is a very serious and very morbid and potentially fatal disease. So in any case, calciphylaxis, I'm sorry I can't get the scan to come into as good a focus, but that one vessel that we showed earlier was pretty good, and all these little calcifications here fit very well for it in the right clinical context. But you have to have the right clinical context. Oh, here's one too. Look at this. See, there's a little tiny vessel lumen in the middle, and then this is a ring of calcium around the outside, and the calcium's fragmenting and falling apart. This is much more florid. Some cases are very subtle and only have very focal calcification. If you get a case like that where the clinical is suspicious for calciphylaxis, and you get a little punch biopsy, consider doing deeper levels. Consider doing a von Casa stain, which will highlight the calcium and turn it a dark brown, brownish black kind of color. And so I find that in some cases you need to use a von Casa stain in deeper levels. And also you need to see subcutis. If you get a biopsy that just shows dermis, still you can try the stain, the von Casa, and the deeper levels. But when I sign that out, if the clinical appearance looks suspicious for calciphylaxis, or the submitting doctor tells me they want to rule out calciphylaxis, and my biopsy shows very little subcutis, I will put in the comment, I don't see calcification in vessels here, but there is minimal subcutis present, and you need to go back and do a deeper biopsy. Ideally, a big wedge or chunk of fat like this is the best way to get a diagnosis or to rule out calciphylaxis. Get a big chunk of fat, usually right under the eschar, or at the edge of the eschar where you get some viable tissue and some dead tissue, and then get all the way down to the fat. So a big ellipse or a nodule of fat taken out is the best way. But if you can't do that, a double punch or telescoping punch biopsy can also work, although you get less tissue, so it's possible that you might not be able to see the calcifications. They're not always this diffuse. So in that case, you can punch the dermis, snip that out, and then punch down again into the biopsy hole and push down deeply into the fat to get that second piece of fat out. But the best is to get a big piece like this. So anyway, I can never talk shortly about this. I'm sorry, I tried to, but I failed. So this is calciphylaxis, and I'm sorry we can't get it in more focus than that, but I'll put a link down in the video description so you can go and see that other video that has better pictures that are more in focus. All right, case 9. Okay.
If we see in dermis, there's a feathery appearing material, and if we look closer, we see like the amorphous material is kind of surrounded by histiocytes. So I would say it's gout.
Very good. Pink, fluffy, cloud-like, cotton candy-like, or I think in some parts of the world they call it candy floss. I think like in the UK it's candy floss. That's what it reminds me of, or pink fluffy clouds. We have not as many histiocytes as in that last case, but there's a few histiocytes around it. When you go closer, like here it looks very amorphous and almost amyloid-like at low power, but once it comes into focus, now we can see it tends to have that kind of very, very thin little slits that look like little needles. But again, even though it looks needle-like, if you polarize this slide here, it'll be negative because it's all been dissolved during processing and staining, okay? Sometimes you can, I've found that you can cut an unstained slide and have the laboratory heat it to remove the paraffin. And then don't stain it. Just look at it with the paraffin melted down or dissolved, but no stain done. And sometimes you can get some of the crystals to polarize, actually. But you don't, I mean, I rarely ever need to do that because this is gout, right? Like nothing else looks like this to me. So in any case, here it's got a darker pink color, but it usually looks this very pale pink. So that's a great example, again, of gout. Case 10.
I think it's back to me. I hope I didn't skip anyone, but I think everyone went. So this one looks like from this power, it looks like there's maybe something abnormal in like the deeper dermis.
Yeah.
It looks like there's just like increased space between the collagen bundles. So when we zoom in, it almost looks like that like material kind of bluish. I think some people describe it as like giraffe skin or like a marbled steak. But yeah, I think so. I think it's mucin, which is between the collagen bundles pretty deep. So this is good for scleroedema.
Very good. A giraffe skin or a marbled steak. I like that. It does look like a very marbled steak here. This is a really good example of scleroedema. And it's just like you said, there is abundant blue mucin, or if you're a pathologist watching this, myxoid material, hyaluronic acid, glycosaminoglycans, ground substance. All those words in this context mean the same thing. So in DermPath, I use the terms mucin and myxoid interchangeably. But it's basically the reticular dermal collagen bundles are separated by deposition of mucin, but there is no inflammation. There is no real significant increase in fibroblast density here. It's just like normal dermis with extra mucin in between the collagen bundles. And it is usually on the trunk, and that's exactly what this skin looks like, right? Epidermis with like a mile thick of dense, regular dermis underneath it, okay? So this case is like almost too good to be true. I find that a lot of cases of scleroedema are much more subtle than this, and you have to kind of look closely for the mucin or sometimes do a mucin stain, okay? A lot of times, I don't see scleroedema very often in practice, but from talking to some of my dermatology colleagues, they've told me they actually see it relatively often in clinic. It just doesn't get biopsy because it's clinically recognizable. So there are a couple different forms, but one of the main forms that we think of is on an adult, on the upper, like back, and it's this dense, firm kind of hardening of the skin. If you try to kind of pinch it, it's hard to pinch the skin because it's so firm and tense. And I think there's some association with diabetes. I think there's also another variant that arises in younger patients, like after upper respiratory infection, like strep throat. Is that correct? Or am I imagining that? Okay.
No, that's right.
Okay, cool. I don't think I've ever seen a biopsy of that again. I think it's probably recognized clinically. And that's it. Now, the difficulty with this disease comes with the fact that it sounds kind of similar to two other things. Scleroedema sounds kind of like scleroderma, which also could get confused with pretibial myxedema. So I have a little chart that shows 3 examples and a quick way to tell them apart, and I'll put a link to that down below. But basically, to tell you quickly, myxoid only or mucin only with no fibroblasts in between reticular dermis, that's scleroedema. Okay? Pretibial myxedema is going to be in the shin, the pretibial area, and it's going to be the dermis, particularly right under the epidermis and down, completely replaced by mucin. So much mucin that it looks like a sea of mucin with displacement of the collagen bundles. So you'll look at it and it won't look like dermis with a little extra mucin. It'll look like mucin with a little bit of dermal collagen left over. It'll look much more blue, not as pink as here. And then scleromyxedema, to my eye, doesn't really look that myxoid. It looks more like a fibrous kind of proliferation in the dermis that has increased fibroblasts, increased collagen, and a little bit of myxoid mucin mixed into it, okay? To my eye, it almost, the few cases of scleromyxedema I've seen almost made me think of like a dermatofibroma or something at first with a little bit of myxoid change, but then clinically it didn't fit. Okay, so in any case, those are the kind of summary of the three things. But I'll put a link below that shows pictures and a little side-by-side comparison for you to remember, because I think they don't really look alike, but they sound alike. So they're derm path name alikes or sound alikes, but not really look alikes. All right, but this is scleroedema. Probably this is the best example I've seen, honestly. Now, case 11.
So looking at this one, kind of like the last one, there's some kind of blue material filling up the dermis, and in contrast, this one goes kind of throughout, like it's up in the upper dermis as well.
Yep.
And that blue material is kind of spacing out the collagen, and it looks like it is mucin as well.
Good.
So when it's both deep and superficial, we think about pretibial myxedema.
Very good. And of course, we got to make sure the site is correct, but this is mucin pretty much filling the dermis, right? In the sense that it's starting to push the collagen bundles out of the way because there's so much mucin here. Much more robust mucin than we saw in that last case of scleroedema. And like I said, that last case of scleroedema was way more mucin than I usually see. That was like almost too good to be true. But here, it's like 10 times more than that. And it comes all the way up here. It usually seems to spare the papillary dermis, I've noticed. But it starts at the beginning of the reticular dermis and just goes down. And it just looks like a sea of blue. From low power, you could also think, man, maybe this is really bad soleoelastosis. But when you go closer, mucin and soleoelastosis look similar from low power sometimes, but when you go closer, the mucin is much more loose. It tends to get kind of bubbly sometimes and clear. It all depends. I find that mucin from case to case looks a little different. It depends. It seems to be very sensitive to how we process and what our H&E is like. And even in the same lab, I find from day to day, mucin can look a little bit different from case to case. So I find that it often gets kind of bubbly like this. Also, sometimes it'll get like little stippled speckles. Like you can kind of see here. It's really better to see that on a glass slide, you know, with a good microscope. It's harder to demonstrate on scans. And I find that mucin's also hard to take pictures of. Things that are very mucinous, it's hard to get the white balance correct, and it often gets really pale on a scan slide or on pictures. Sometimes it's hard to get the blue appearance. But here it's really nice. You can see it pretty good here. Pretibial myxedema usually presents as pretibial plaques, and they will kind of have a thickened appearance. And remind me, what kind of color does it look like to you guys when you've seen it? Have any of you seen it in clinic yet? Maybe not. I sometimes don't have a sense of like how common things are clinically, because how often I see them biopsied doesn't always correlate with how common their incidence is in clinical practice. But in any case, I think they're often erythematous, but I want to say they can maybe be yellowish sometimes. I might be wrong about that. In any case, you can go look it up if you're watching online. But they can be thick and plaque-like on the anterior shins, but also they can sometimes not be. There are a couple other variant forms clinically. Sometimes they can present as one or multiple nodules. And I've seen cases that were biopsied that looked like erythema nodosum clinically. Multiple erythematous nodules on the shins, and they looked like this microscopically. And there's also I've never seen a case of it, but it's been described as a kind of elephantiasis-like distribution where the whole lower leg is swollen and looks massively larger. And that can also be confusing clinically, but on biopsy it shows diffuse mucin. And so what is this disease often associated with?
Graves' disease.
Graves' disease, right? So the other name that can be used for this is thyroid dermopathy, I believe. And so oftentimes these patients have Graves' disease. Sometimes this can present before the patient actually clinically has obvious Graves' disease. I have seen a couple cases where they did not yet know the patient had Graves' disease, and it was from the biopsy, and we told them pretibial myxedema, check this patient's thyroid function, and then it came back with a very high T4 and a very low TSH, and they had Graves' disease. They had hyperthyroidism. So it's a good disease to be aware of because it can sometimes be an indication that they have thyroid disease. Okay, Graves' disease. And also, I do find that sometimes they get increased pigment in the basal layer. So see this case, how there's increased pigment? And so I've noticed that before too, that you can have a pigmentation. What was the other thing? Oh yes, I don't know, I've never seen it, but I've read about that some people speculate that the reason that some patients with Graves' disease get exophthalmos, the eye protruding, is because of some myxoid deposition in the extraocular muscles or the soft tissues behind the eye. But obviously, no one ever biopsies that, so I don't see that microscopically ever. And I have seen one case that I speculated that looked like this in the dermis that also had mucin infiltrating the underlying skeletal muscle to the extent that it was thought to be like a myxoma on imaging. And actually, we've been meaning to publish that. I guess I'll have to check on the status of that. Maybe it's still waiting on the resident to finish writing it up. But that was kind of an unusual case that I saw that I think fit best with this. But in any case, there you go. Pretibial myxedema.
Looking at this, it looks like there might be an area of scar where like a biopsy might have been done.
Very good.
The epi is a little effaced, and then there's like the area of scar underneath it.
Yeah, from low power you can see normal epidermis, but in the middle it's abnormal, right? It's kind of sunken and depressed in this case. The reedy ridge pattern is altered. In some areas it's totally flat and atrophic with no reedy. Other areas it's kind of a little thickened, so it's a little epidermal hyperplasia, reactive change from regrowth. And the dermal collagen, even from low power, it's actually better to see from low power. Normal dermal collagen, and then suddenly it's altered and looks different, and then back to normal over here. So yeah, that's a biopsy site change. We can see it in 3 areas. We'll come and zoom in over here. We'll probably see, so this is scar from a biopsy, and then we get a little bonus finding here. Okay, what's going on here? Tell me about these cells here.
Oh, there we go. I can see it now. So these cells, they're picking up aluminum chloride.
Very good. Yeah, so this is aluminum chloride, or I guess one of the brand names is Drysol, that is used by dermatologists particularly, but sometimes by other doctors after doing biopsies, particularly after a shave biopsy. Then they put aluminum chloride on top of the bleeding shave site, the wound, to stop the bleeding. So kind of a chemical cautery. And then what we get microscopically is a variety of changes. In addition to the scar, you will see histiocytes here of variable amounts. It varies from case to case. I think it depends maybe on how much Drysol is used, maybe the anatomic site, and also maybe how long after the biopsy we see the excision specimen. So this must have been like a cancer, and then they went back and re-excised it, and now we're seeing the whole biopsy site plus the adjacent normal skin. And so in this case, unfortunately, this is the best scan that we've got, but you get these histiocytes with increased granular bluish gray, kind of stippled, speckled cytoplasm. So you can see these kind of like dots here in the middle, and then this grayish blue cytoplasm, and that's on these histiocytes. So these are histiocytes that have phagocytosed the aluminum chloride and eaten it up. And some people say that these little speckles in the histiocytes could resemble like leishmaniasis or histoplasmosis, which are also intracytoplasmic organisms that live in histiocytes. So I've heard people say that if you're having a bad day, you might mistake these little histiocytes for having organisms inside them, when in fact this is just aluminum chloride. I don't even mention this in the report. So this is mainly just an incidental curiosity that if you look at this and start wondering, oh, could it be a parasite or a fungal organism? No, it's not. It's just aluminum chloride. So it is important every once in a while, because sometimes you'll get an excision and you've not been given any clinical history, and no one's told you that the reason they're excising this is because a previous biopsy had been performed and the diagnosis was melanoma or something else. They just may say lesion and excise it. My dermatology colleagues, of course, always give me good history, but occasionally some other colleagues just send me an ellipse of skin with no history. Which is always kind of sad to me, but I can usually figure it out, because if I find a couple of these histiocytes, then I know someone has done a biopsy and put aluminum chloride on it, and then that prompts me to go investigate and figure out why is this excision being done. So this can be really helpful to tell you, yes, there's a history of biopsy here. Also, it can be helpful if someone's excising, and occasionally sometimes a biopsy site can heal so well that it's hard to see clinically where the biopsy was done, especially if a patient has a lot of scars on their skin. You may wonder which one was the recent biopsy. And this is a great, yet another great reason why we should always take clinical photographs before biopsies. It's a great idea to do because there's many times that photograph can be enormously helpful and potentially increases patient safety and avoids legal issues. So I highly recommend all people doing skin biopsies, please take a picture beforehand. I have seen so many times where that saved the day. Plenty of times it's not needed, but when it's needed, it can be a really big help. But in cases like that, sometimes finding the aluminum chloride can help me determine, yes, we do have the biopsy site here. So these are the histiocytes. I have a longer video of this with much better example on my Kiko page and my YouTube. You can see down below. I'll put a link in there. And there you go. So that's aluminum chloride. And then the other thing is that sometimes, is there a better area of it here? Oh yeah, right here. But I don't know if it'll come into focus anytime in the next 10 minutes. We'll see. Sometimes also the collagen fibers seem to get kind of burned and calcified from aluminum chloride. This doesn't always happen. Again, I don't know why some cases show really robust aluminum chloride change and some do not. But in any case, it is sometimes seen, and so I want you to be aware of it. But what happens is you get these kind of distorted, discolored, calcified collagen fibers. So the collagen gets kind of squished, smushy, homogenized and smudgy looking, and turns like kind of a darker reddish color and or purple color. So like all of these like weird looking fragments here are all fragments of kind of like chemically burned and calcified collagen fibers from the aluminum chloride. You can see they're kind of starting to turn purple in here. Here's some fragments of kind of calcification. All of this spectrum of things that we're seeing here is related to aluminum chloride. And despite this, it doesn't seem to cause any problem on the skin surface. Seems like aluminum chloride works really well and doesn't produce discoloration of the skin, whereas some other agents that I've seen other doctors use, like silver nitrate or older agents like Moncel solution, can sometimes leave discoloration of the skin surface. So I'm not sure why people still use those, but I do see some other colleagues and other specialties sometimes use those instead of aluminum chloride. No one pays me to promote aluminum chloride. I have no idea. I've never used any of these things, but except I do use aluminum chloride actually when you're shaving. If you cut yourself, you can buy a little stick. It's called a styptic pencil. It's a kind of an old-timey thing, but it's a stick of aluminum chloride and it works really well. It stings and hurts, but it works really well to stop bleeding instead of putting a little bit of tissue paper on your face. So again, I'm not paid by big aluminum chloride. If there is such a thing, please seek me out and send me a check. I'd love to get one. But in any case, just so you know, that's the only association I have with aluminum chloride is I've tried it for shaving. And if you never have, go try it. It's like $2 for a little bit of this. You can buy it on Amazon or somewhere. So there you go. Case 13.
All right. So again, it's floating, but we can see from this top piece at least that the entire dermis is filled with like this pink kind of amorphous material again, reedier face, so something is kind of pressing up on it and taking those away from us. Lots of fissuring or cracking, and so I think this is good for nodular amyloid.
Very good. This is amyloidosis in the dermis, and here it is making a nodule. So this is a little bit of a confusing terminology, I find, but here we'll look at the amyloid first, then we'll talk about words. So homogenized amorphous pink material. Sometimes there are other things that make amorphous pink deposits, and multiple people have asked me, please make a video comparing all of these. And I've kind of put it off because they are challenging, and so I got to put together some good cases, and it's actually a little hard sometimes to explain. Amyloid, I feel like, is often a little easier because you've got the nice cracking artifacts. So just like the keratin-derived amyloids, they make cracks, so does the light chain-derived amyloid, the true amyloid that we see in association with systemic amyloidosis sometimes and light chain amyloids. Okay, you get these cracks, but look at it. It's not just in the papillary dermis. It goes way down and fills up the dermis in this case. So sometimes you get diffuse filling of the dermis in amyloidosis. Sometimes you just get perivascular deposits of amyloid, okay? And we've got the cracks, but we don't have the pigment trapped within them, okay? So this type of amyloid is usually going to be light chain derived amyloid. There are some other types of amyloid, though, that are not light chain. One example that I've seen is insulin associated amyloid. It's usually down in the subcutaneous fat on the abdomen of diabetics who inject themselves with insulin, and over the years they get buildups and deposits, and it looks just like this, but it's filling up the fat and trapping the fat. And I've seen a couple cases of it where I was worried about systemic amyloid, but then I saw it was a nodule in the abdomen and the patient was diabetic. And so that's why usually when I find amyloid where it's diffuse and filling the dermis or is in the subcutis, anything that's not obvious keratin amyloid, I usually send it for mass spectrometry, which can identify what type of amyloid it is, if it's light chain or AL amyloid, and then the patient needs to get worked up to rule out systemic amyloidosis. If it's like, other type of amyloid like insulin deposit, well, then that's not associated with anything systemic amyloid-wise, okay? So I think it's really helpful if you have access to that in your practice. The mass spec I send out for that, and it's nice because we get an answer, because a person who has light chain amyloid is going to get significant additional workup, and they may potentially have a very serious and potentially life-threatening disease, okay? So this brings us to the question of what is nodular amyloidosis? I think it's confusing because it sounds like the name looks like it should be a nodule. Well, yes, it is, but nodular amyloidosis is the term that refers to light chain amyloid that is forming skin deposits but is not systemic. It's only in the skin. It is on mass spec identical to the kind of amyloid that you see in systemic amyloid. Both of them are produced by clonal plasma cells. Both of them are made of light chain. Both of them are AL type amyloid on mass spec. Okay, both of them look identical microscopically. Both of them stain with Conga red and get that apple green birefringence if you have the right setup on your scope and really bright light source. Again, that's one of those things that look beautiful in textbooks, but I think is actually harder to demonstrate in real practice. They're both positive for thioflavin T and other amyloid stains, etc. Okay, but if you do a bone marrow biopsy or clinical workup, these patients won't have amyloid anywhere else. It will just be in the skin. And one clue to nodular cutaneous only light chain amyloid is the presence of plasma cells within the infiltrate. So the idea is that they are still clonal plasma cells, but for some reason they're just hanging out in the skin and they're locally making the amyloid here. Some of these patients will later develop systemic amyloid is my understanding from reading. So I feel like these patients do need to get followed probably to make sure that they don't have systemic amyloid, and they do need workup to rule out systemic amyloid. But I have seen patients with this that even 10 years later have normal cardiac function, normal bone marrow biopsy, no other evidence of progressive disease, and that just have skin-only deposits of amyloid that look like this and are light chain and have plasma cells. And these plasma cells, I believe, will show up as clonal on a kappa and lambda in situ hybridization. That's my understanding. It's been a while since I've seen a case, but yes, that they usually are clonal plasma cells that are depositing the amyloid, the light chains here, but it's just building up in the skin. So in any case, that's the kind of process I go through to work it up, and I usually have to write a comment to explain. So can systemic amyloid make nodules that look just like nodular amyloid? Absolutely. So to me, the only way to distinguish these definitively is to work them up, do the bone marrow biopsy, and the additional clinical workup steps to exclude systemic amyloid. But one clue is the presence of plasma cells here in the middle of the infiltrate, okay? So there we go. I hope I've explained that well enough. I find it really hard. It took me well into practice to wrap my head around it. All right. So this is a good example. A nice cracking artifact here, right? And there is one other thing that looks a little like this. It's called colloid milium that I still don't fully understand, but it's kind of like degenerated nodules of protein and cellular elastosis mixed together. And I've seen a case of, actually it ended up being systemic amyloid, that deposited in older person and sun-damaged skin that looked kind of like this. But actually, because of the elastosis, I thought it was going to be a colloid milium. But then we did mass spec. It was amyloid. So if you're thinking about colloid milium, always keep amyloid in mind. And if there's any doubt, send it out and do mass spec. I find mass spec to be really helpful for working up these cases. All right.
All right, so for this one is I can see like in the low power is the blue tube picture in the dermis that is like you can see the mixed mucin with fibroblast picture. So this is could be good for scleromyxedema.
Very good. Yes. This is scleromyxedema, assuming the clinical workup and everything and the clinical appearance is right. To me, this reminds me, maybe it's because I'm a soft tissue pathologist and I like spindle cell lesions. This looks like a spindle cell proliferation in the dermis. It's got some collagen trapping, and it's got spindle cells that are like bland fibroblasts, maybe some histiocytes, and then a variable amount of mucin as well as kind of an alteration. The dermal collagen looks a little different than normal, a little smaller. So it looks kind of like a fibroblastic collagenous proliferation with a variable amount of mucin mixed in. It reminds me, to my eye, the few times I've seen it, it looks kind of a vaguely like a dermatofibroma, but with myxoid or mucinous change. So I don't know if that works for you, but for me, anytime I see something that looks like a DF, but has some myxoid or mucin, I always think, could it be scleromyxedema? The reason is that DFs, surprisingly, rarely ever have myxoid change. And that's really surprising because DFs have like 30 different morphological variants, it seems like, but myxoid is not really one of those. I mean, I have seen, I don't know, 1,000 DFs, and I rarely ever see myxoid change, and if so, very focal at best. And it's weird because many soft tissue tumors have a myxoid variation, but DF for some reason does not seem to be one of those. So always be very cautious. If you think something's a DF with myxoid change, think of this. Think of other spindle cell tumors. Be very wary of making that diagnosis. Just throwing that out there. Scleromyxedema is a kind of complicated topic. It's quite rare, in my experience at least. Sometimes it presents as multiple papules all over the skin. I think people describe it as what the chicken skin appearance. Is that right? Or am I confusing that with something else? Yep. Okay. And then there's also like plaque-like forms. It can be associated with monoclonal gammopathies and other systemic problems. So it's a potentially a systemically problematic disease. So these patients need to get more workup. Okay. And you can go and read it more in depth because there's a lot of different things that are associated and problems that these patients can have. But microscopically, remember, this is one of the name-alikes that sounds kind of like scleroedema, pretibial myxedema, and scleromyxedema. All have kind of similar sounding names, but they look quite different, right? Here we have some mucin, but a lot of increase in spindle cell density and alteration of the kind of collagen in a way that looks kind of fibrotic or fibroblastic proliferation. All right, so scleromyxedema in this case. Or I believe the other name sometimes used in the papular form is papular myxedematosus. Is that right? Sorry, I meant to go and look up all these things because these are things I don't see and write reports on very often. And I meant to do my homework before this session, but, you know, life happens sometimes. Here's the other slide. Is that right? Can someone tell me, is it papular myxedematosus? Or am I making that up?
Papular mucinosis.
Papular mucinosis. Thank you. Thank you very much.
Lichen myxedematosus.
Lichen myxedematosis. I was hybridizing the names. Okay. Lichen myxedematosis. And it's good to learn the variant names of things, which is very frustrating in dermatology and dermpath, but you never know which name's going to show up on a test, so it's good to know the different names, and you know, it's a little extra work, but you're learning a couple different names for the price of one, right? See, look again, like how it kind of resembles dermatofibroma. Or maybe you could think of interstitial granuloma annulare here, which to me also kind of resembles dermatofibroma. So I think those things morphologically could all be in the differential together. Case 15.
Okay, so we see a little bit hyperkeratosis and collagen bundles in the dermis, and there's a like slight pinkish bluish hue under the epidermis, like kind of lichenoid appearance. And when we go high power, we see, as was in the first case, I think, like lots of pigment incontinentia and some keratin derived, I think, amyloid with cracking artifact on the papillary.
There we go.
So it's called like lichen.
Yeah, this is very subtle. Honestly, most cases I see of lichen amyloid, again, this is the one that's usually on the lower legs, thickened papules or plaques on the pretibial area, the shin, and it usually has epidermal hyperplasia and papillomatosis like this, but often like even full-blown lichen simplex chronicus because it's itchy, I think, and people itch. And I don't know whether the itching drives the production of amyloid or the amyloid makes it itchy or it's kind of a chicken and egg thing. So this one is actually pretty subtle. And really, if you told me that this was from the upper back, I'd say it's macular amyloid. If you told me it's from the lower leg, I'd say it's probably lichen amyloid. To me, these are two kind of clinical variations of the same basic process, keratin amyloid deposition with pigment incontinence. Here we have very, very subtle focal crack like keratin amyloid deposits, much more abundant pigment incontinence. Otherwise, if you looked at this, you might think just it's post-inflammatory pigment alteration, PIH, pigment incontinence. And maybe you could also think of like, CARP or acanthosis nigricans, depending on the clinical. The amyloid here is very subtle. But anyway, anytime you see kind of pallor of the papillary dermis with some pigment dropout, go and look around and see if you can find some amyloid deposits. Here's a little bit right here. Very, very subtle, very tiny focal cracks you can see there. This is a really subtle example. Honestly, if you would ask me to guess, I would say this probably is macular amyloid from the upper back rather than lichen amyloid. So I don't know the clinical history here. It's labeled as lichen amyloid on my answer sheet, but it also says, could find a better example. I agree. But it's a good example of how subtle it can be. All right? Keratin-derived amyloid, whichever name you use doesn't matter, but just recognizing it's keratin-derived amyloid and pigment incontinence. All right, guys, we're down to the wire, running out of time like usual, so I'll just go through the rest of them to try to get them done in time. Here we have pale dermis, and the collagen bundles are pushed apart and replaced by mucin or myxoid material. See, when we get closer, we can see it's very pale in this case and washed out, as often happens as the slides age, like I told you. But it's bluish mucin, and if we did a mucin stain, or probably if we just cut a new H&E from the block that's not as old, we would see the nice blue mucin. But you can tell here that it's pushed the dermal collagen apart. Sometimes if it's an older slide or a pale slide, you could also wonder, is it edema? Actually, edema and mucin can look pretty similar microscopically, I think. And here you can tell it's like just a little tiny nodule of it microscopically. It's so small that clinically this probably just looked like a single papule. And you can see there's also a little collarette, where there's an eccrine duct and some elongated epithelium that's scooping down under the lesion. Sometimes this will have that. But if clinically this is a small papule, and that's all we have, and microscopically we see increased mucin, this is called focal dermal mucinosis or focal cutaneous mucinosis. I do not know why this happens. It's just incidental little papule or little microscopic collection of mucin that is localized and it is not associated with any other disease to my knowledge. If you just gave me a punch here and told me it was from the pretibial area, then I'd tell you this would be great for pretibial myxedema. If it was, nodules or diffuse plaques on the shins. Okay, so the clinical really matters here. All right, the one thing this sometimes can also get confused with is a cutaneous myxoma, or also known as superficial angiomyxoma. I have other videos about that. The difference there is those are usually bigger. They usually go deeper into the dermis and even into the subcutis. And as the alternative name, angiomyxoma, implies, they usually have more prominent vessels. Sometimes they also have scattered neutrophils scattered in the middle of them, or cystic hair follicles or sweat ducts. Not every case has all of those things though. So the biggest thing to me is if it's a tiny little papule clinically, it's probably just a focal dermal mucinosis, focal cutaneous mucinosis. Occasionally I can't tell, or I don't have good clinical info, and I'll say it's dermal mucin collection, and that it could fit for focal dermal mucinosis, or it could be the surface of a cutaneous myxoma, depending on the clinical. And it doesn't matter, it's benign either way. Only difference is that cutaneous myxomas do have a tendency to recur locally if they're incompletely excised, but they're still benign. And occasionally they can be associated with Carney complex, particularly if they're multiple or if they're on the eyelids, the ears, or the nipples. But otherwise, in other sites, cutaneous myxoma is benign and not usually problematic. All right. But in this case, it was a small papule, so it was focal dermal mucinosis. This is case 17, and the dermis here is completely replaced by pink. The pink is homogeneous, amorphous material with crack-like artifact between it, so it's amyloid. This could either be nodular amyloidosis, which is, again, light chain amyloid localized only to the skin without systemic involvement, or it could be a cutaneous deposit from systemic amyloidosis. We must have clinical workup and usually a bone marrow biopsy to distinguish between those. Here, it's filling the dermis. Notice how the papillary dermis is not involved here, and the rest of the dermis is filled up, okay? That's how we know this is probably light chain amyloid and not keratin amyloid. So this needs more workup. Sometimes it densely aggregates around eccrine ducts, eccrine coils, hair follicles, okay? But it usually fills the rest of the dermis also. And when you see vessels, it often deposits right around vessel walls, particularly if you get a larger, thicker muscular vessel. It will often have dense deposits in the vessel walls. Here we can see some depositing around a small vessel wall right down here. All right, so this was light chain amyloid, and either nodular, it's labeled as nodular amyloidosis in this case, but it certainly would have to be worked up to rule out systemic involvement. All right, and the one thing I would say is that sometimes sclerotic collagen can be hard. It's one of those other homogenized pink things that can be hard to tell apart from amyloid. I'll have to make another video to explain, but one thing that helps me is on a regular microscope, if you go closer and you get right up here and you flip the condenser, in collagen you'll see little thin collagen fibers that are wavy and refractile, and in amyloid there are fibers, but they are really, really tiny and can only be seen by electron microscopy because they're so small. Much, much smaller than collagen fibers. Collagen fibers can be seen by flipping the condenser, usually on a light microscope. And amyloid, even when you flip the condenser, it still looks homogeneous, okay? It also is a little bit different color. You can see here's a collagen bundle that's left over. It's a little bit of a more a deeper pink red, and amyloid's a little more of a light color. And again, you can use stains like thioflavin T and Congo red to help. And also fibrin can look a little like this. Fibrin, though, is even more red color, and you can do some stains to help tell that apart. Trichrome is helpful. Trichrome will stain amyloid kind of a grayish blue. It will stain collagen a deeper blue, although those are pretty similar. And then fibrin will stain usually red on trichrome. So I find trichrome sometimes helpful in that differential. But usually I go to thioflavin T or Congo red, although like I said, that's a finicky stain unless your lab gets it really optimized. This is a epidermal hyperplasia. This was a little papule on a child's eyelid, or right around the eye of a kid, and there's epidermal acanthosis, and then right in the dermis underneath, there are fragments of calcification, little nodular aggregates of calcium, sometimes making little pools of granular fragmented calcium. Here there are actually bigger chunks of calcium. The calcium sometimes gets entrapped in the epidermis or surrounded by the reactive epidermis, and usually these are one or multiple papules around the eye of children for some reason. So this looks just like calcinosis cutis, but when it occurs in that special location right under the epidermis around the eye in kids, it's called the subepidermal calcified nodule. And to my understanding, this is just an incidental idiopathic finding that is not usually associated with any sort of systemic disease process to my knowledge. So I don't know why this happens, but it does seem to happen around the eyes in kids, and is usually when I've seen it, it's just been single nodule, but I think it can sometimes be multiple, and no systemic association that I'm aware of. Usually just biopsy because it's a bothersome little papule on the eye and they're wondering what it is, and then it's just calcium. So subepidermal calcified nodule, but otherwise microscopically looks very similar to calcinosis cutis. All right, I've sent the residents to clinic because I've gone overtime as usual, as happens every Friday when I do these. I just can't do 20 plus cases in an hour and 15 minutes. It seems like breaks the laws of physics, at least my laws of physics. Here we have mucosa. It's stratified squamous epithelium, And in the surface here, once it comes into focus, we'll see it does not have a stratum corneum. It does not have a granular layer. Sometimes when you get irritation of squamous mucosa, it will get a little granular layer and or a little bit of parakeratosis or thick orthokeratin on top. So, but usually in its normal state, you do not see a granular layer and you do not see a corneal layer on top. Also, to tell us it's mucosa, you don't see adnexal structures like hair follicles, all right? And then the third thing that helps us is squamous mucosa usually has increased glycogen content, so it gives this pale, washed out appearance to the keratinocytes. They look very pale and different, whereas in skin, the keratinocytes are much more dense pink cytoplasm and not so pale. Okay, so that's a little quick rundown of how to tell squamous mucosa, stratified squamous mucosa, like you'd see on the lip, in the mouth, in part of the in the esophagus, and also in the vagina or the labia minora or the anus. Those are most of the sites that have squamous mucosa normally. Okay, so in this case, I'll tell you we're in the lip of the mouth. And you have squamous mucosa, and down here you have abundant skeletal muscle bundles. So that's how we know we're probably either in the lip or the cheek, the internal buccal side of the cheek, or in the tongue, although tongue will have much more abundant skeletal muscle that usually fills the entire area underneath the squamous mucosa. All right, so that's kind of how we can sort out where we likely are. If instead of skeletal muscle we had, say, smooth muscle bundles here, and then squamous mucosa, then we'd probably be like in the vagina or the labia minora, okay? So here we go. Down here, though, we have another finding that tells us we're in the lip, probably, and that is this structure here, as it comes into focus. And this multinodular aggregate of small glands is a minor salivary gland, and these glands are made of small acini that have cells with abundant blue mucin. So these are mucinous cells making little acinar structures that cluster together into little lobules. And then those little lobules drain into ducts of increasing size, and the ducts are layered, lined by a double layer cuboidal lining. Small salivary ducts have a double cuboidal lining. As you get into larger ducts, the inner lining gets more columnar. To my recollection, I'm not a head and neck pathologist, but that's my memory of it. I hope I'm telling you that right. But about the only places we see double layer cuboidal epithelium in pathology is in salivary ducts and in eccrine or apocrine sweat gland ducts. So when you see a double layer cuboidal, 2 layers of round nuclei lining an empty space, sometimes filled with a little bit of secretion, then you know that you're dealing with either a salivary duct or a sweat duct, okay? So there's some normal histology knowledge for you. And these, because we've got the little mucinous acini, we know that these are salivary, and they're minor salivary glands in this case. And what's happening here? Let me go back to low power again. Over here, right next to our intact salivary, minor salivary gland, we have a large dilated cystic space. It is surrounded by a layer of fibrosis and maybe a little bit of granulation tissue and some mixed inflammation. And it is not lined by a true epithelial lining. At first glance, you might think so, but actually these are histiocytes, okay? If you weren't sure, you could do a keratin immunostain to help you decide that these are truly not epithelial cells. Instead, these are histiocytes, and they have puffy cytoplasm that gives them the appearance of epithelial or epithelioid cells at first, but they're not arranged in a nice, organized, tightly connected layer like a true epithelium would be. They're kind of haphazardly arranged here and compressed together to give you kind of a pseudo-epithelium, but they're actually histiocytes, and if we go closer, it may not show up nicely on this scan, but they have a bubbly or frothy cytoplasm. That's because these are filled with the myxoid mucinous material, and that is actually mucin from the salivary gland secretion. That mucin that is made by the minor salivary gland gets put into a larger salivary gland duct. Sometimes those ducts get clogged and ruptured. Sometimes you can actually see a portion of the large duct impacted by dried up, hardened concretions of salivary secretion called a sialolith. It may get calcified sometimes, and those can obstruct the duct, leading the duct to enlarge, distend, fill with mucinous material, and eventually rupture. And the ruptured duct, the mucin secretion spills out makes a cystic space here in the adjacent soft tissue, and that space gets surrounded by fibrosis and reactive changes, some granulation tissue here, reactive blood vessels, lymphocytes, histiocytes, some neutrophils, and variable amounts of histiocytes that sometimes are filled with mucinous material, and those are sometimes called muciphages. And those muciphages may fill the space, or they may line up and layer along the edge. The reason I'm telling you all these different variations is because from case to case this can vary. Sometimes you'll see the duct here and it's beautiful. Sometimes all you'll see is the fibrosis and a little bit of muciphage and a little empty space. And here the space is empty. You can't actually see the mucin here because it washed out and washed away during tissue processing in the laboratory, okay? So that's why when you don't see the mucin, you need to depend on all these background findings. If I see a nodule on the lip and I see some histiocytes in an empty space and it's near some minor salivary, I'm going to suggest that it's probably a mucocele. So this, I can't remember, maybe I didn't mention the name yet. Sorry, if I didn't, the diagnosis here is called mucocele, or sometimes people will call this mucus extravasation phenomenon. The mucus is coming out of the duct. I always think of extravasation as meaning coming out of a vessel, but here we use the same word for extravasation I use for blood cells coming out of a blood vessel, but I guess we can use it for other things too. It's coming out of a ductal space here. Mucin is spilling out. So in any case, here you can see nice muciphages layered around the edges, and they're beautiful muciphages floating in the center of this space here. All right. You could confuse these potentially with xanthomatous cells. I feel like the xanthomatous cells have much more sharply defined vacuoles, and they're more clear. But I feel like they do look pretty similar. Foamy histiocytes with lipid versus foamy histiocytes with mucin material in them can look pretty similar here. But in this case, the context and all the other findings tell us this is a mucocele. So a nice, perfect example of one, but sometimes you won't get such a perfect sample as we see in this case. This is case 20, and this is an example of what happens when you take a piece of gout from a gouty tophus, and instead of putting it in formalin and doing regular tissue processing and H&E staining, instead you put it into alcohol, ethanol, and fix it with ethanol, and then cut it and do not apply any H&E stain. And what we get here is a aggregate of gout crystals that have not been dissolved. And so that's why it's totally pale, because we don't have any H&E stain applied. And if we go closer, you can see these areas here, they have a brown, this squiggly line is an air bubble. And the reason there's an air bubble here, air bubbles happen because there's not enough mounting media between the cover slip and the slide. And often that happens, sometimes that happens due to defects in the cover slipping equipment. But other times that can happen if you have something thick that didn't cut as thin as a normal tissue section, which we normally cut around 4 microns. And thick things can mean bone calcification or foreign material that did not cut well, and so it left a thicker layer, and that pushed the cover slip up and left this air bubble because there wasn't enough mounting media to fill the space in. So sometimes if you see big air bubbles like this, it's a clue that maybe there's something hard and potentially either foreign, crystalline, or calcified, or bone in your specimen. So you can consider going to look for that to see why, okay? And here, look at the other clue is that the color, everything else is clear, but this area is a brownish, grayish, black color. And if we go in closer, and this won't show up well here, but it really shows up well on a light microscope where you can flip your condenser, and well, here it actually is showing decently. You can see there's a refractile nature to this material. These are crystals, and these crystals have not dissolved. So whenever you're thinking about gout and you see an area of grayish, brownish, black coloration and a more refractile appearance, especially if you flip your condenser, you can really highlight that three-dimensionality. It looks like it stands out from the tissue. I can't really show that, or those are words I'm trying to explain, but you got to see it with your own eyes on your scope. Oh, you know what? You can actually see it right here. See how this tissue looks like it's kind of 3D. It kind of is out of focus even more than the rest of the tissue because it's kind of coming out of the tissue at us. It's a little thicker, and so it's not focused as well as the rest of the tissue. and you can see the needle shape kind of appearance here. So these are gout crystals that have not dissolved, and if you put the polarizer in, they'll glow brilliantly. And if you go to my Kiko index, or I'll try to remember to put a link down below, I've got some nice examples of what the polarized gout crystals look like on a smear, and I've got another gout video that shows what they look like on a sample kind of like this. Okay? So anyway, ethanol fixed and unstained section of gout. And sometimes even in regular formalin fixed and regular processed, regular H&E sections, you'll see little fragments in the middle of the pink nodules of gout. You'll see little areas that look this color. If you do, go and put your polarizer in and polarize it, and you'll be in for a nice treat, because polarized gout, as terrible and painful as it is for patients, it's quite beautiful microscopically, and I think anyone could agree about that. So in any case, sometimes a little bit of gout, even if you don't do this special processing, sometimes a little gout survives the processing and staining, and will show up like this little black or gray fragment on the regular H&E section, and that area will be the area that will polarize. All the stuff that looks pink like fluffy clouds or cotton candy, that stuff's gone, and it will almost never polarize. But the areas that look refractile and grayish brown, those are areas that are still left over gout. And the reason I think they're grayish brown is I think there's even without a big air bubble, I think tiny little bits of air get in there, and that makes the tissue look a little refractile, and makes it not look at this darker color. Because actually, when you focus in, the crystals are not actually dark colored. This is just an artifact of three-dimensionality and air and not focusing correctly. Some combo of that, it gives the light, makes it look kind of blackish, but it is actually not. These are not pigments in crystals. Just wanted to clarify that, because I know here they look like it, but they're actually not. It's just an artifact of the way the light is refracting coming through the slide. All right. Okay, so here's an example of a smear from gout that's either was air dried or fixed with alcohol. I usually just like them air dried, honestly. And then when you polarize it, you get these beautifully birefringent, thin needle-shaped crystals. And you can see that in some areas they're haphazard, but in others you can see how they're kind of arranged in like a bundle, like a sheaf of wheat, like in the old-timey days where they would wrap wheat together standing up in the field. I think that's where the word sheaf came from. I don't see wheat ever really done that way anymore, at least not where I live. But in any case, this bundled package of crystals here is, you can see that, and then if you go look at the pale pink areas on an H&E section of gout where the crystals are washed out, you can kind of see the shadow of this same appearance of multiple stacked collected bundles of crystals haphazardly stacked together, and then that's what gives that kind of appearance, okay? So that's a nice example of what polarizable gout crystals look like. Case 21 is going to be a nodule that is often clinically they're either thought to be a cyst, or sometimes because they have a kind of chalky white appearance, the dermatologist might recognize what it is if they're close enough to the skin surface. So this is an example of pilomatricoma, or pilomatrixoma. I like how it looks better with the X when you write it, but it's easier to say when you put a C in and say pilomatricoma. Both ways are totally accurate. This is a benign hair follicle tumor, and it is recapitulating what happens in the hair root or hair bulb. So what you're going to get is blue basaloid matrical cells in some cases, and then those will transition into sheets of keratinocytes that are starting to die and have dissolving of their nuclei. So they leave just a shadow of the sheet of keratinocytes. So we call these shadow cells or ghost cells. You can see the shape here. There are lots of little keratinocytes arranged in a sheet, but they don't have any nuclei. They're just pink. The keratin is left, but the cells are dead and the nuclei are gone. And what's happening is just like the normal hair follicle, the blue basaloid cells at the base produce keratinocytes that eventually die and get packed together. The keratin's packed together into a hair shaft, and that's how our hair grows. It's a normal process. The keratinocytes are supposed to die. So the same thing is kind of happening, but in a much more disorganized, haphazard way in this benign hair follicle neoplasm, pilomatricoma. Okay? In this case, we don't see any blue basaloid cells. Let me look around at low power. All we see are the ghost cells, and the variable reactions to those ghost cells, okay? So some cases have abundant blue basaloid cells and a lot of mitoses and look very scary, but they're totally benign. But it's good to go and familiarize yourself with that. I've got some whole slide examples and videos about that on Kiko. But a lot more often what I see is this kind of pilomatricoma, where we just have the ghost cells and then they're all arranged in disorganized fragments. They're a nodule from low power that's usually pretty circumscribed. And then at closer look, haphazard, mishmashed, rearranged, or I'm sorry, I don't know what the word I'm looking for is. Haphazardly arranged or mishmashed, some people would say, fragments of ghost keratinocytes, dead keratinocytes with variable amounts of calcification. Calcification is very common in pilomatricoma. Sometimes it's focal. Sometimes it just starts to make like little rings of calcium around the sheets of dead keratinocyte ghost cells or shadow cells. So you can tell the shadow cells, which normally look kind of a pink or orange, or as some of my residents like to say, they like to say peachy pilomatricoma because it has a kind of peach, orangey pink peach color. And I like that. The keratin actually really does often have this kind of peach color. I don't think I was ever taught that, but my derm residents, recently a couple of them taught me that, and I'm appreciative because I think that's a beautiful terminology. So peachy pink pilomatricoma, and then that pink color starts to turn more and more blue and purple as calcium deposits on this dead keratin and eventually makes thick, fragmented, cracked aggregates of calcification. And sometimes that can even progress all the way to metaplastic ossification or heterotopic bone formation, okay? The reason it's good to know about this calcification or ossification is when it's abundant, beginners who have not seen this phenomenon before will look at this and think calcinosis cutis or tumoral calcinosis because it's islands or pools of fragmented calcification with fibrosis, and oftentimes you'll get some giant cell histiocyte granulomatous type reaction around these islands, okay? And so you'll think calcinosis cutis. The key here in telling this apart from calcinosis cutis is to go down and find those islands or those sheets of shadow cells or ghost cells, the keratin content, okay? That's the key. Once I see those, this is not calcinosis cutis, this is a calcified pilomatricoma, okay? And or if you find sheets of blue basaloid cells with some mitoses, that would also be evidence that we're dealing with a pilomatricoma that's calcified. I don't think this case has bone. I have some other videos that show examples of that online, but if you have abundant bone, you might think it's an osteoma cutis. Again, if you find blue basaloid cells or you find the peachy pink sheets of ghost shadow cells, then you know it's actually a pilomatricoma with bone formation. And oftentimes the ones with bone also have calcification in them. And here's some area of the giant cell reaction. Pretty much all pilomatricomas seem to rupture and get disorganized fragments, and that usually in all the spilled keratin contents into the dermis. The dermis does not like keratin to be loose. It's okay to be inside a cyst. It's okay to be in a hair follicle. It's okay to be on the skin surface. But once it gets loose in the dermis, it is contacting naked dermal collagen. The dermis reacts with, the immune system reacts with a kind of explosive mixture of granulomatous response, and you'll get histiocytes, granulomas, giant cell reaction all around the keratin, and fibrosis too, okay? So that's why a ruptured cyst will provoke such inflammatory response and granuloma formation, because the dermis and the immune system do not like free keratin for some reason, even though I don't know why. The keratin's harmless. And the same phenomenon happens when you get a pilomatricoma. This one has actually very little granulomous response. Some of them have a lot of granuloma. And the other thing I wanted to point out is that from low power, they're usually circumscribed. But when you get a fragmented biopsy of a pilomatricoma or a punch biopsy of pilomatricoma, it has the appearance of infiltration because it's so haphazard. And so especially when you get that plus blue basaloid cells, people start getting worried that it's malignant. And especially when you see mitotic activity. Again, this case does not show that, but some cases do. And it's important to see some examples like that and to recognize that those end up almost always being benign. There is a malignant variant of pilomatricoma called matrical carcinoma or a malignant pilomatricoma or various other names. Those usually have marked atypia, atypical mitosis,
That's the thing I'm looking for. They usually look obviously malignant, not like pilomatricoma. Usually they have focal pilomatrical areas, but look really like a malignant high-grade tumor in my experience. I have only rarely seen them that looked like pilomatricoma at close-up, but because of clinical or because of extensive infiltration away from the main mass on excision, that it was clear that they were malignant. But usually they look obviously ugly in my experience microscopically. In any case, that's more detail than you need. This case, no one would ever confuse, I think, with malignancy because there's like no viable cells here. And then, oh yeah, also you can get, there's some slit-like keratin spaces. Cholesterol granulomas look very similar to keratin granulomas to me. I'm not sure which this is, but I would vote that it's probably a keratin granuloma because we have all this free keratin around. So there you go. Calcified pilomatricoma. And here what we see is we're probably from the scalp or maybe the face, somewhere with multiple large hair follicles. But these hair follicles have an abnormality. They do not look normal. They are distended and enlarged, and their epithelium is expanded and much more pale. And when we look closer, the reason for that is that there's abundant mucin within the hair follicle epithelium. We see mucin filling up the lumen of the hair follicle and also infiltrating in between individual keratinocytes of the follicular epithelium. And sometimes it's obvious blue mucin. Sometimes it washes out and looks a little more spongy. So if I see hair follicles that are really distended and look pale and spongiotic, sometimes I'll maybe do a mucin stain or look closer for mucin because I've noticed sometimes the mucin can wash out a little bit. But most of the time when I've seen this, it looks obviously blue at closer look. So multiple follicles are involved. Look at this follicle here, this one here, this one here. So the follicle epithelium is expanded by mucin. And there's also a lot of lymphocytes scattered in the follicle epithelium and around the follicle. So this is called follicular mucinosis. And this is an important disease to know about because it is associated, at least in some cases, with mycosis fungoides, particularly the folliculotropic variant of mycosis fungoides. Now, there is some debate over whether all cases are associated with mycosis fungoides. I have heard some dermatopathologists say that they believe all follicular mucinosis is a variant of mycosis fungoides. I've heard others say that that's not true, and I tend to side with the latter point, that I've seen some cases that did not seem to have the patients had had it for a long time and didn't seem to have any progressive disease or other signs of mycosis fungoides. And so at least some books have said that there's kind of a couple different patterns. Number one, you can see follicular mucinosis associated with mycosis fungoides, particularly folliculotropic MF, in which the mycosis fungoides, which is a variant, for anyone who's a beginner, it's a variant of cutaneous T-cell lymphoma. Okay, most often, cutaneous T-cell lymphoma, mycosis fungoides, is clonal T-cells that infiltrate the epidermis and have epidermotropism, but sometimes they can infiltrate the hair follicle epithelium or surround hair follicles, and they may do that by, with the coexistence of epidermal involvement. So you can have both epidermal involvement and follicular involvement by mycosis fungoides T-cell lymphoma. Other cases tend to just have hair follicle involvement for some reason. Okay, and those are important to know about because they can be harder to diagnose clinically because they don't look like other forms of MF clinically. They can also be harder to diagnose microscopically because if you get a case that's only involving focal follicles, you may not see it until you cut deeper into the block. I've seen cases that just had little pinpoint papules clinically, and on initial section there was nothing, and then deepers, it was folliculotropic mycosis fungoides. Okay? So in any case, I've got another video about that you can go watch that has a better example and goes into more depth about folliculotropic MF. Mycosis fungoides is a complicated topic, even complicated to me still as a dermatopathologist. So in any case, some cases of follicular mucinosis are associated with MF. I find it challenging to tell apart MF in the background of follicular mucinosis. Sometimes, like in a case like this, we have increased lymphocytes. They're not very atypical. So in a case like this, we could do immunostains to try to see if these were, all CD4 positive or all CD8 positive, or if they had loss of CD5 or CD7. I find that those stains are often challenging to interpret, particularly in more subtle cases of MF. You can also do T-cell receptor clonality studies to see if this is a monoclonal T-cell process. Those are also imperfect because some cases of MF, especially earlier stage cases, will have false negative T cell receptor analysis. And also sometimes you can have clonality in follicular mucinosis that doesn't progress. So again, it's really complicated and is kind of an area of some degree of controversy. And I am not a hematopathology expert. You can go and read the writings of those people who know much more about it than I do. But in any case, one form of follicular mucinosis is associated with follicular tropic MF. But some people have proposed that there are at least two other scenarios you can see it. One is you can see it as a reactive phenomenon associated with other types of dermatosis, like inflammatory conditions. And then three, that you can see as an incidental phenomenon that is idiopathic and does not progress on to have mycosis fungoides. So I don't know for sure, but I've heard that it proposed that those are three potential scenarios. I do think that if you see this in multiple follicles, and that it's at least worth looking into the clinical scenario to consider if this patient might have a need for more workup to rule out mycosis fungoides. And also, if you start seeing a lot of lymphocytes with it, you may want to consider doing immunostains or T cell receptor clonality studies or consultation with a dermatopathologist who has some experience with hematopathology to see if they think that there could be potential for mycosis fungoides here. In any case, this pattern right here, follicular mucinosis, and you can then go read and consider what other workup might need done. All right. All right, here's a punch biopsy of skin, and the first thing, there's two things you might notice. Number one, the dermis, to me, looks abnormal. When you first start out, it's a little harder to see abnormalities of the dermis when they're pink, I think, because you think, well, the dermis is supposed to be pink and not have many cells. But especially if you can see it next to a normal piece of dermis, this is definitely abnormal. For one thing, the collagen is very dense and thick, so we have fibrosis and sclerosis mixed together here. And for another, we have these nodular pink aggregates. These are granulomas. I'll show you at a closer look in a minute. So that's one thing here, is we've got scarring of the dermis with granuloma formation. The other, and you can see some of these little round pink nodules in the subcutis. These are also granulomas. Granulomas are aggregates of histiocytes. Sometimes they come with necrosis, sometimes they don't. Sometimes they come with inflammation, sometimes they don't. In this case, we have like tight little granulomas without any significant lymphocytes or neutrophils. And from this power, I don't see much in the way of necrosis. Okay. So the other thing that you might notice is there's a bad sectioning, right? And you might think, well, why did the histotechnologist not cut this well? It's not their fault. Something is in the tissue that's causing this problem. Okay. These streak-like tears through the tissue are, see how there's multiple of them? They're what I like to call the Wolverine effect. And I think that I'm the first person to coin this term. Hopefully DC Comics will not come after me for this and say I'm violating their trademark. So in any case, the reason I have this idea is that this looks to me like Wolverine, the X-Men, took his adamantium claws and slashed across the tissue in a fit of rage. Okay, maybe that's a little bit too imaginative, but that's what it makes me think of. When you see these tearing streaks, this is a nice clue, even though it's ugly to look at, it's a nice clue that there is something hard in the tissue, something that is firm and hard and not easily cut. And so when the histotechnologist takes the block of tissue and is trying to cut the thin section, these hard fragments in the tissue get caught and drug across the microtome blade and or nick the microtome blade so that it doesn't cut cleanly through the tissue. And it results in these tears that streak across the tissue, okay? So when I see this, this is a sign. Go and look for something foreign or calcified or pieces of bone or pieces of something hard that is not dissolved during tissue processing, okay? So a lot of times this is a good sign for foreign bodies, foreign material, or fragments of calcification or bits of bone that did not get decalcified during processing in the laboratory. From here, we can already see these little pockets here, how they have some grayish black fragments in there. And if we had this on a light microscope, we could flip our condenser and you would see that they stand out and are kind of three-dimensional. These are the fragments of foreign material that even from low power, I can see them there. There's some right there. This is what's in the tissue that's causing the streaking Wolverine effect. This is why the tissue has scarring and fibrosis. This is why the tissue has granulomas. Even from low power, we can see that. So it's an important clue. And the reason it's good to see this from low power is at low power, you pick up on the streaking. And at low power, you can see the granulomas because in some cases, the foreign material might be very focal. And you may go to high power and miss it. And you want to look from low power, and it will give you the clue that, hey, this is where we're going to find foreign stuff in here, okay? And let's go closer and take a look. These fragments that look black, gray, kind of colored, are foreign material. Now, just from looking at it, I have no idea what this stuff is. All I can tell you is this did not come from inside the patient's body. For one thing, we've got some material here that actually looks probably truly black. Sometimes it's hard to tell because refractile things can look a little blacker on the edges, like this piece here. This looks like a little crystal that's actually probably clear, but around the edges sometimes it can look kind of black because of the refractile nature of things. Little black particles can also be metal fragments. Little tiny fragments of metal can have a black appearance. Tattoo. I find that oftentimes foreign material, because it is often gets into the skin through trauma or penetrating injury. I mean, almost always that's how it gets in. It's either injected, or the person had a motorcycle accident and their skin got ripped open and gravel and sand and dirt got in there, or they stepped on a stick and a piece of wood with dirt on it got shoved into the dermis, or they injected drugs, or they had a medical procedure. Something had to happen to cut through the epidermis and allow outside material to get into the skin, right? Almost always it's through penetrating injury of the epidermis, okay, through some way. I guess systemically you could have fragments, but it would be it's pretty unusual for that to happen. In any case, this usually means injuries happened and the material got in there somehow, whether intentionally or unintentionally, okay? In this case, the history I don't have, but this was silica, silicosis of the skin, and this is in people with various types of industrial work, working with rock or sand, where they get powder of different types of rock or mineral that have silica or silicates in them, and those powdered fragments can get inhaled into the lungs and cause scarring and granulomas and deposits of silica in the lung. Or in this case, they got penetrating injury. I'm not sure the mechanism here, if it was sandblasting related or what. I don't know the history here, but this is labeled in the answer sheet from this study set as silica granulomas. The main thing, though, is in this case, maybe someone out there, maybe a lung pathologist who knows more about silica, can tell me why this is silica, not something else. But I would say that oftentimes foreign material, I am unable to identify microscopically what it is, but I can at least tell the dermatologist what we have here is foreign material and foreign body reaction. Because sometimes there's a history and they know, other times there's a nodule or a plaque or something and there's not a known or reported history. And so telling them this, they may think that it's a tumor or something, and biopsying it to rule out tumor. I've seen that multiple times where a small nodule was thought to be a skin cancer, or I've even seen large deep nodules, like I saw one once on the wrist of a patient. Big deep nodule, it presented as a mass. The patient was worried about it, came in, they did imaging studies, it looked like a deep mass. They sent it to the sarcoma surgeon for biopsy, and or I think they biopsied it and did a frozen section and then excised it afterwards for treatment. But there was a concern that it could be a soft tissue tumor like a sarcoma. And at the time of frozen section, what did I see? I saw streak artifact, I saw refractile material, and I saw granulomas, and I said, this is foreign body granuloma. Turns out the patient had injured themselves many years ago, like decades ago when they were a child. They had actually, I think, smashed their arm between a car door and the corner of a brick wall, and fragments of brick had gotten stuck in there. The injury was like really deep down to the bone almost. And that material stayed in there for decades, and even decades later, the histiocytes were still trying to work on that granuloma. Foreign body granulomas seem to never give up. I've also seen an example of a suture that did not dissolve from a C-section that worked its way up from the abdominal fascia area or deep soft tissue and eventually perforated out and spit itself out of the skin surface, and it looked like it was a ruptured cyst clinically. And when this was when I was a fellow in clinic, and when we went in there to curette and excise the cyst contents, there was a big chunk of suture material tied in a knot in the middle of that. And the patient said, oh yeah, I had a C-section, and their child was, I think, 30 something. All those years later, the foreign body granulomas kept working on that foreign material. So in any case, just so you know, sometimes the history of injury was many, many years ago, and the patient may have forgotten, and only once it's brought up by their treating doctor, they say, oh yeah, I remember now. So that's always satisfying. Sometimes I get that answer and find out what the material was. Many times I never find out, which is always disappointing. But in any case, this is labeled as silica. Now you know those stories. Hopefully that you'll find them helpful. And here, these vague pink nodules of spindled spindled to epithelioid cells. Sometimes they have a kind of plump spindled nuclei or oval nuclei. Sometimes they have more round nuclei. They have abundant pink, pale, pink or gray cytoplasm that kind of merges with the neighbors, forming a syncytial aggregate. That's a granuloma. Okay, these granulomas are a little subtle and vague. If you're a beginner, you may not recognize them as granulomas. These are a little bit better. They're a little bit more round. Some people like to say these are epithelioid histiocytes, but they don't have to look epithelioid. They can be spindled, they can be round, they can be oval. Granulomas are nodules of histiocytes aggregated together. Sometimes they're tight in little tight balls like this. Sometimes we will call these sarcoidal granulomas when they're tight, round, pink balls without much inflammation. Sarcoidosis can make sarcoidal granulomas, but so can foreign body, and so can a variety of other diseases, both foreign body reactions, leprosy, and cutaneous tuberculosis can sometimes have a sarcoid-like appearance. When you see granulomas, go look with a polarizer for foreign material. If you don't find foreign material, or if you have any concern for infection, you may want to do infectious stains like GMS or PAS to rule out fungus, Phyte stain or other acid-fast bacillus stain to rule out mycobacterial infection. And once infection or foreign material has been excluded, then you can consider maybe this could be cutaneous involvement by sarcoidosis, but that's a diagnosis of exclusion. Clinical workup is needed. It has to fit with the clinical. And I've seen times where people just have granulomas in the skin, no systemic signs of sarcoidosis, no signs of infection, no foreign material, and they just have granulomatous disease in the skin with no obvious other systemic involvement. I don't know what name to apply to this. So sometimes I see granulomas where we don't understand why they're there. I don't know if any of you encounter that in your practice, but I found that, and I found it to be kind of frustrating. But in any case, these are granulomas. Here's more granulomas here. Here's more granuloma, and in the center here, this open space, that's where some of the foreign material was, and some of it fell out during processing. Because it's hard to cut. Sometimes it pops out of the tissue. We can see a couple fragments around the edges, but the middle's an empty space. So keep that in mind. Granulomas with empty space, that's a good clue also that you may be dealing with foreign material. See these empty irregular spaces here? Those probably were fragments of foreign body, that most of which got knocked out and dislodged during tissue sectioning. More granulomas here, pink nodular aggregates, okay? And then over here, let's look down in the subcutis to see more views of the granuloma. I realize I've never made a video about like what a granuloma is and how to define it, but basically it is a nodular aggregate of histiocytes, and there are various different flavors of that. This granuloma right here could be is a kind of sarcoidal granuloma like the other ones I showed you. It's a tight nodule of histiocytes, and in this case we've got a little giant cell in the middle, a multinucleated giant cell. So some granulomas have giant cells, sometimes they don't, okay? Foreign body granulomas tend to have a lot of giant cells, but just so you know that you don't have to have giant cells to have a granuloma, okay? Sarcoid tends to have very little inflammation around it, but again, this case is not sarcoid. This case is foreign body granuloma, and it doesn't have much inflammation. So you can really have a spectrum, but I just wanted to let you know this is what granulomas look like, and they can have giant cells. Sometimes they have necrosis, sometimes they have inflammation. But if you see a granuloma with necrosis or with neutrophils, that's a good time to really be suspicious for infection. If you see granulomas in association with streaking artifact like this, go look for foreign material. All right. This case was silica, cutaneous silica, foreign body granuloma. And here we have case 24. From low power, the epidermis looks normal. The top of the dermis, as it comes into focus here, looks pretty normal except for a little perivascular lymphocytes. But down here, this part of the dermis is disturbed and disorganized, right? There's this vague, hazy kind of ring shape, and there's some increased cellularity here. And if we look closer, we can see that the outside of this vague ring shape has increased cells with bland, round oval nuclei and increased pale pink to gray cytoplasm. These are histiocytes. And the histiocytes here are forming this vague aggregate or kind of ring around a central area of degenerated collagen with myxoid or mucin material mixed in with it. You can kind of see this bluish haziness right here. This is an older slide and a kind of poor quality scan, so you can't see it very well. But on a fresh cut slide and a nice example, usually you can see that it's blue mucin. Not all cases have a lot, but this is mucin and degenerated collagen. Usually there's a decreased amount of fibroblasts in this area. It's because the collagen's starting to kind of die and the fibroblasts are dying in here or degenerating. So the term we use for this is necrobiosis. It's kind of a fancy term for kind of subtle necrosis of the dermal collagen, usually with mucin, and usually surrounded by palisaded or lined up ring of histiocytes. Now, palisaded means like a picket fence-like or fence-like arrangement, and these are not really that great. Like sometimes they really line up in a nice, perfect wall of histiocytes all layered, but more often they're kind of irregular like this. So this kind of irregular, slightly palisaded ring of histiocytes surrounding degenerated collagen with mucin. This is the perfect classic feature of granuloma annulare, which is an idiopathic granulomatous process. And the word annular is from the Latin for a ring. And it's kind of cool because it is both ring-shaped microscopically in most cases. Sometimes it's kind of a vague, subtle ring, but you can kind of see a ring of histiocytes wrapping around this central necrobiosis. But it's also ring-shaped clinically. It looks like an annular ring-shaped lesion, kind of with a raised edge and a flat or maybe slightly depressed center, depending on the case. Not all cases make a ring, but I really find it quite satisfying that it's both annular / ring-shaped clinically and microscopically in many cases. Now, not always. Some cases microscopically, particularly if you don't get a nice cut through the middle, just show histiocytes that trickle between the collagen here, okay? So I'd like to point that out. The histiocytes in granuloma annulare are often vaguely aggregated rather than tightly formed into tight nodular granulomas like we saw in that last case of foreign body granuloma, okay? So that's one important thing to note, that it's granulomatous, but the granuloma here is not your beautiful classic granuloma of like sarcoidosis or tuberculosis or a foreign body reaction. The granuloma in this entity is much more vague, subtle, kind of lazily grouped histiocytes. I think that's an important thing for pathology-trained people to recognize, that many things that we call granulomatous in DermPath are not actually well-formed nodular granulomas, okay? What we usually mean are rich in histiocytes. Sometimes we mean just the infiltrate has a lot of histiocytes in it, and we'll call things like granulomatous drug eruption, often just has kind of an increased histiocyte density in addition to lymphocytes and some other findings, and we'll say, oh, it's granulomatous. So we use the word granulomatous and granuloma very loosely in dermatopathology, I would like to say, compared to the rest of pathology. I think so, at least. So don't be surprised by that when you start DermPath. It's also worth noting that the word granuloma sometimes came from historical names based on the clinical appearance, and the word granuloma was because the forefathers of dermatology thought that clinically the lesion looked like a granulomatous thing. But now, after further examination, after we developed microscopes and started looking, we realized, oh, there's actually no granuloma at all microscopically, okay? A couple good examples of this are pyogenic granuloma, which is actually a form of hemangioma, lobular capillary hemangioma. No granuloma at all. The only granuloma there is in the name, not microscopically. Another example would be a granuloma faciale, which has a mixture of all sorts of inflammatory cells that fill the dermis, lymphocytes, histiocytes, plasma cells, neutrophils, eosinophils, but really no granuloma formation whatsoever. Just the granulomas in the name only. And there are other examples we won't go into. So just be aware of that. Some things are called granuloma clinically, but have no granuloma or really no histiocytes microscopically. Other things are called granuloma because they have increased histiocytes but don't form nice, well-formed granulomas. So that's an important thing to know about granuloma, the word granuloma in dermatopathology. Back to granuloma annulare. The histiocytes here form vague aggregates around the edge of the necrobiotic collagen and mucin, and then they trickle and intercalate between dermal collagen bundles, kind of wrapping around and entrapping these pink dermal collagen bundles. The reason that's important is, A, that's a pretty common classic finding that is almost always present in GA, in my experience. The other reason I want to bring it up is that if you don't see the central necrobiosis and you just have this, it looks an awful lot like the edge, the peripheral edge of a dermatofibroma. Dermatofibromas classically have collagen entrapment at their periphery, and that's also what GA does. And when you just have this pattern of collagen trapping and don't see good mucin, we actually call this the interstitial pattern of GA, or interstitial granuloma annulare. In my experience, I feel that usually, even though we call it like it's a separate variant, I feel like it's really a microscopic pattern that we see when we're just sectioning the edge of GA. Oftentimes on deeper sectioning, I'll find areas that look better for regular GA. So I have had a hard time finding a good case of interstitial GA that is only interstitial by itself. And oftentimes I kind of get backed into that diagnosis, and I feel like it's usually just that we're just not getting the best area on the biopsy or on the section we're looking at. So in any case, just so you know, that interstitial pattern, when you see that alone, think about granuloma annulare for histiocytes trapping collagen. Even if you don't see the mucin, consider cutting deeper or trying a mucin stain. Look at the clinical to see if it could be GA clinically. All right. Another thing, so I would think it's fair actually, and I think early residents often struggle, and on cases they'll think of dermatofibroma in the differential with GA, and I think that's totally fair and reasonable to recognize that those can look similar at the periphery. You just will not have a central zone of mucin in DFs. As I said earlier in the full video of this session, dermatofibroma, despite having many, many morphologic variants, myxoid is really not one of them. I've never seen a really good example of a DF with abundant myxoid change. I've rarely seen focal myxoid or mucin change, but very rare and very focal. So DFs have a lot of flavors, but myxoid ain't one, okay? If you think it's a myxoid DF, you better go think of some other things first, okay? Like scleromyxedema, like we talked about earlier, or like GA. All right. The other thing that can do this pattern, that is another granulomatous disease that we're not going to go into here, is there's a group of granulomatous diseases called reactive granulomatous dermatitis, and they encompass a spectrum of diseases, including interstitial granulomatous dermatitis, which tends to have a lot of collagen trapping, and some of the collagen bundles float and are wrapped tightly by histiocytes with a little space, but they're nice palisading. And then there's also, when there's it looks like GA but has neutrophils in it, a lot of neutrophils, there's something called palisaded neutrophilic and granulomatous dermatitis. So the abbreviations or the acronyms for those are IGD and PNGD. And the reason it's good to recognize them is they both kind of have overlap with granuloma annulare, but oftentimes have an unusual clinical presentation that's more extensive than GA, and they look more robust or more unusual microscopically, and they often are associated with internal systemic diseases. They can be drug-related, they can be associated with rheumatoid arthritis or other rheumatologic disease. Sometimes they can be associated with leukemia or lymphoma or internal cancers. So oftentimes in those cases, patients need more workup. That does not apply in a case like this of classic granuloma annulare. That fits with classic granuloma annulare clinically, all right? Oh yeah, GA often has eosinophils. That's a common finding, actually. I don't feel like people talk about it a lot, but I often see EOs in GA. I think some people have found like 30% or so of GA have EOs. Okay, the last thing I was going to mention is that in your differential between dermatofibroma and GA, hypopigmented blue nevus also traps collagen at the periphery. It can look a lot like a DF, maybe a little bit like a GA, but usually the cells are thinner in blue nevus, and they're almost always going to be a little bit of melanin. Even in the very hypopigmented blue nevus, there'll be some melanin. So that's a differential you can keep in mind. Hypopigmented DF, hypopigmented blue nevus, dermatofibroma, and the interstitial areas at the edge of granuloma annulare all have collagen trapping and can look alike. Okay, the final thing I got distracted from at the beginning, apologies for that, is that I said GA is annular or ring-shaped microscopically usually, and also usually clinically. Clinically, GA presents as ring-shaped lesions. I did mention that, and so it's important to remember that that sometimes it will get confused with other things that are annular and ring-shaped, like dermatophyte fungal infection or tinea, sometimes known as ringworm outside of dermatology circles and to the non-medical public, okay? So those can be ring-shaped, usually more scaly and less indurated, but that's another thing. So if they thought it looked like a tinea clinically, and then I start seeing histiocytes microscopically, we're probably dealing with granuloma annulare. And then also there are forms of lupus that clinically, like SCLE form of lupus, can make ring-shaped lesions clinically, and so that's another thing. If they were thinking about lupus and you see histiocytes microscopically, maybe it's actually granuloma annulare. All right. Sometimes granuloma annulare, though, presents just as papules, particularly like on the dorsal fingers or dorsal hand. And so that form doesn't have necessarily a ring shape. And also there's a deep form of granuloma annulare that often presents as one or multiple nodules deep down in the subcutis on the lower extremity, usually of kids or young adults. And it will look like this, usually a lot bigger and more robust, and it'll be down deep in the subcutis a lot of times, and can sometimes mimic rheumatoid nodule. So we got a lot of talking done about granuloma annulare. I'll put some links below to give you more things to look at in this differential. This is a nice classic one, but it's a good disease to familiarize yourself with because there's a lot of different flavors and topics that kind of tangentially relate to this pattern and to this disease. All right, that brings us to the very end of the session. The dermatologist went off to clinic long ago, and since they weren't here, I got a lot more long-winded and verbose, but hopefully some of you online found it useful. Thanks very much for watching. Have a great day, and I'll put links below in the video description.